Thank you so much for the kind invitation. I'm very sorry not to be able to join there in person. I will speak today about heart failure with improved ejection fraction, how to approach heart failure remission. This is the list of my conflicts of interest. We all know very well how to classify heart failure based on ejection fraction. This is the previous classification from the ESC guidelines, which we don't know, it might soon even change in the next version of the guidelines. But we had a very static definition based on EF less than 40 FREF, between 40 and 50 MREF, and over 50 FPEF. However, is ejection fraction a static parameter? It is really not. Here we see data from the Swedish Heart Failure Registry we published quite some years ago, and you can clearly see that of patients with a baseline ejection fraction lower than 40%, actually over 25% had an increase in EF over time. And as well as you can see that among those with an EF, which was over 50% defined as FPEF, there were also those who were reporting a decrease over the time. So we need to talk about trajectories when we approach, of course, the classification of heart failure. And who are the patients who are more likely to change EF? Of course, if they have FREF, those receiving GDMT might be more likely to improve. Those who have triggers for having a lower EF, such as those with an AF which is rapid and might be slowed down, so those are more likely to improve. Patients with COPD might be more likely to improve, whether COPD might be properly treated, and patients who are better follow-up in specialty care, and patients who are having a better follow-up for heart failure itself. Of course, you see that patients with improving EF have better prognosis as compared to those who are not improving, but you can see that at 1 year in our study, this had still a risk of around 20% of mortality or heart failure hospitalization, so they are still at risk. Here you see another important study, again data from Sweden, where you can see how EF is dynamic, so it's changed over time during the life course of our patients, and it becomes even more variable whether patients get older. So again, don't consider EF as a stable parameters. Whether EF improves, there is an improvement in heart outcome, as I showed previously, but also an improvement in quality of life in many patients, as you can see reported here in this study from 300 patients from a tertiary hospital. Those who improved EF had better KCC score, physical functional score, and satisfaction score, so patients may feel better. In more contemporary data, this is the titrate HF study, you can see that among patients with a low EF, a great proportion actually increased in EF at 12 months follow-up. And this increase was mainly observed in those patients who were receiving better GDMT in terms of use of medications and achievement of target doses. So in this position paper, we tried a little bit to define who are those patients more likely to improve, and also to summarize what we know at the moment regarding heart failure with improvement, ejection fraction, recovery, EF, and remission. And here we clearly summarize that those patients who are more likely to improve in EF are those with non-ischemic heart failure, those who have a clear trigger for their reduced ejection fraction, such as a transient myocardial insult, which can be a TACO-ZUP or peripartum cardiomyopathy, chemotherapy-induced cardiomyopathy, and so on. So once you remove the trigger, EF might improve. Those who do not have the specific genetic mutations, those who do not have long-standing comorbidities, and in particular those whose comorbidity can be treated as, for example, atrial fibrillation with an ablation. Of course, patients who are younger and with shorter duration of heart failure, and of course, those patients receiving GDMT and with good compliance. So can we identify those patients more likely to have a remission of their heart failure, and probably if this remission is long enough to have a recovery. So here we report the echocardiographic measures, so 1% increase in GLS or 10% actually increase the chance of heart failure with improved ejection fraction, specific LA strain, and of course not having fibrosis at MRI. So these are important parameters you might remember. Heart failure with improved ejection fraction is defined as reported here in universal definition of heart failure. So an initial EF less than 40% with at least a 10 points increase for baseline in EF and a second measurements over 40%. But actually this definition increases so many different patients, and therefore we really highlight the need of having a better granular definition, better phenotyping our patients. That's how we came out with the concept of remission and recovery that you can see reported here. We define remission as an EF which became over 50% with at least 10 points increase as in the previous definition as well. But also we highlight the need of having minimal or no symptoms in these patients to define remission, and defined as an EA class 1 or 2. There should be minimal residual abnormalities or closer to normal cardiac structure and function. And we also highlight that in these patients with a temporary normalization, risk of events is still there. In general, we suggest that in these patients where there is remission, GDMT should be continuing until we are sure that there has been a recovery. So indeed, recovery is defined whether patients have no symptoms at all, NIA class 1, there is no any more structural cardiac abnormalities. It's persistent for 12 or over 12 months. And this means a complete or permanent recovery, and therefore here the risk of any further events is very low. And therefore in these patients there might be a start of the discussion with the patients regarding eventual withdrawal of GDMT. Of course, this is not fully supported at the moment from clinical trials, although evidence is coming and there is much discussion regarding this point. But how to treat heart failure if EF improves? Let's see trial evidence. So patients with heart failure with improved ejection fraction were in the DELIVER trial where DAPA was tested, and in the FINE Arts trial where finerenone was tested. And in both trials, whether patients with improved EF were randomized to the treatment as compared to placebo, there was still a benefit in terms of heart outcomes of these treatments as compared to placebo. But these were patients that we define in our consensus with improved EF. You can clearly see that these patients were still at high risk with high NT-proBNP levels, and also high proportions of patients in EA class 3 and 4. So of course these were patients who were not in remission, so with very low risk, defined as a recovery of their heart failure as well. However, in very old and previous trial, beta blocker was shown that whether it was withdrawn in patients with this DCM, very small population here, there was actually a worsening in NIA class that actually improved once again whether metoprolol was restarted. So you see that based on the population and where the trials were run, there is still difference there might be differences in results. Indeed, but still consistent with the previous trial on beta blockers. In the TREAD-HF trial, again, patients with non-ischemic cardiomyopathy with improving EF becoming such as NT-proBNP was normalized, and also volumes were normalized at the follow-up. Whether you can see here that whether actually treatments were withdrawal, there was an increase in the risk of outcome, which is defined as reported here. So if we look at these trials I've been showing until now, it might seem that whether you withdraw treatments in these populations, there might be an increase in risk. The evidence is slightly different in the STOP CRT trial. So this is about withdrawal and neurohormonal blockade after CRT implantation. You see that whether EF improved following the implantation of CRT, there was no difference between withdrawing GDMT or keeping patients on GDMT. Very, very few events. So of course, this is hypothesis generating, but not really answering the question. The withdrawal AF randomized patients with actually heart failure, which was due to AF, and therefore 60 patients with rhythm control AF and normalized EF following sinus restoration were randomized to withdraw GDMT as compared to keep going with GDMT. Actually, after rhythm controlled AF and normalized EF, whether GDMT was withdrawn, there was no difference in EF at the follow-up. So it seems that withdrawal was actually not harmful. In the Cathedral HF study, patients were randomized to similar approaches, and once again, there was no difference in outcome between patients, although you can see that the events were very, very few. So once again, this is hypothesis generating, but not really answering the question. It's also true that if these patients have so low risk, we should consider whether the question is relevant. In the Swedish Heart Failure Registry, we demonstrated that whether patients withdrawn GDMT and the EF was improved. Actually, there was a worsening in cardiovascular mortality or heart failure, but whether the EF was improved over 50% and beta blockers were withdrawal, actually there was no impact on clinical outcomes, highlighting that probably there might be differences whether one or another treatment is withdrawal. So for beta blocker might be one case, but for the others might be another one. And regarding the story of withdrawal of beta blockers in patients with improved EF, the bonfire is indeed at the moment testing this hypothesis, 1,300 patients in France, where these patients who have what we will say recovered EF or remission of EF, they have no or mild symptoms, basically are randomized to beta blocker discontinued or beta blocker being continued, and it will be tested at 1 year, actually heart failure relapse, mortality, hospitalization for cardiovascular reasons. In defibrillators trials, we saw that whether EF improved in patients randomized in these trials over 35%, and patients were on ICD because it was implanted previously. Actually, there was still a benefit of defibrillators, highlighting that probably the risk of sudden cardiac death might be there even if ejection fraction improved. Therefore, we really call for a better phenotypization for these patients. Don't forget that within the improved ejection fraction, different phenotypes might coexist at the moment in patients in remission, so still with mild symptoms and mild structural activities. We suggest continuation. At the moment, there is no strong evidence from trials in this position paper, but whether there is recovered ejection fraction, meaning normal cardiac structure, ENIA class 1, and the persistent actually lack of symptoms, lack of structural abnormalities, probably we could consider a shared decision making with our patients to consider withdrawal whether they feel it is needed, but definitely more evidence from clinical trials is needed. Thank you very much for your attention.